Are you able to see the presentations, Prof?
Yes, we are able to see. If you could just speak up a little bit.
Okay, sure. Good afternoon, all. Thank you for the introduction, Prof, and thank you to the conveners for allowing me the opportunity to present our research. The title of our research is The Prevalence and Determinants of Burnout in Medical Doctors at Public Hospitals in Gqeberha during the COVID-19 pandemic, a cross-sectional study. My supervisor is Prof. Adams, and my co-supervisor is Dr. Ntatamala. For today's presentation, I'll start by defining burnout and then continue with a brief introduction followed by the research question, aims and objectives, and methodology with a brief discussion of the measurement tools used in the study. Thereafter, I will discuss the results, discussion and limitations, and conclude with a few recommendations. Burnout is a term that is often bandied about frequently in workplaces, and according to the World Health Organization, it is defined as a syndrome resulting from chronic workplace stress that has not been successfully managed. According to the ICD-11, it is characterized by 3 dimensions. Firstly, feelings of energy depletion or exhaustion. Secondly, feelings of increased mental distance from one's job or feelings of negativism or cynicism related to one's job. And thirdly, feelings of reduced professional efficacy, which could be real or perceived. Prior to COVID-19, studies revealed considerable variability in burnout prevalence estimates amongst doctors, ranging from between 0 to 80%. Recent studies conducted locally reported a burnout prevalence rate of 84% amongst registrars at VITS and a burnout prevalence rate of 59% amongst doctors at 5 KwaZulu-Natal public hospitals. In our institutions in Gqeberha, during 2019, we noticed increased numbers of younger doctors presenting with burnout symptoms to the occupational health unit. These doctors had no previous history of mental health illness. However, in 2020, COVID-19 presented itself and increased the burden on doctors by increasing their workloads and their job stress, related to the fear of infection, the fear of infecting loved ones, and the lack of PPE, thus making them even more vulnerable to burnout. Historically, doctors working in the Eastern Cape have been faced with daily challenges in the workplace. These challenges were confirmed by the 2021 Public Protector Report, which revealed systemic deficiencies such as acute staff shortages, inadequate physical infrastructure, shortage of medical equipment, and insufficient supply of resources like PPE. By negatively impacting on capacity and resources of the healthcare system in the Eastern Cape, the COVID-19 pandemic has increased the challenges and job stress faced by doctors, thus increased their risk of burnout. However, to date, there have been no published studies regarding the prevalence and determinants of burnout amongst medical doctors in Gqeberha during the COVID-19 pandemic. Therefore, the aim of this study was to determine the prevalence and determinants of burnout amongst medical doctors at public hospitals in Gqeberha during the COVID-19 pandemic. The objectives were threefold. Firstly, to determine the prevalence of burnout in medical doctors at public hospitals in Gqeberha during the pandemic. Secondly, to identify individual and occupational stresses which contribute to burnout in doctors during the COVID-19 pandemic, as well as to assess the level of resilience in doctors. And thirdly, to propose preventative interventions at an organizational level to successfully reduce burnout amongst medical doctors. For this study, the research question posed was as follows. What is the prevalence of burnout and the factors associated with the burden of disease amongst medical doctors in public hospitals in Gqeberha during the COVID-19 pandemic? Approval for this research study was sought from and granted by both the University of Cape Town Faculty of Health Sciences Human Research Ethics Committee and the Eastern Cape Health Research Committee. In addition, permission to conduct research at the 3 hospitals was also sought from and granted by management. In terms of methodology, a quantitative descriptive cross-sectional study was performed at 3 hospitals in Gqeberha. These hospitals included in the study were Livingstone Hospital, Port Elizabeth Provincial Hospital, and Dora and Ginza Hospital. Livingstone and Port Elizabeth Provincial Hospital combined make up the Livingstone Tertiary Hospital, and Dora and Ginza Hospital is the regional hospitals. At the time of the study, there was a total of 430 doctors employed at the hospitals. The participants consisted of interns, community service medical officers, registrars, specialist consultants, and clinical managers who were all registered with the HPCSA. A pilot study was conducted in March 2022 to enlist the doctors' feedback regarding the relevance and clarity of questionnaires, and these questionnaires were amended as necessary. The main study was conducted between April and May 2022, which coincided with the 5th wave of the COVID pandemic in Gqeberha. For the study, email addresses and mobile phone numbers of the doctors were provided by the HODs and the clinical managers. Using RedCap, an invitation with an attached link to the questionnaire was emailed to the doctors. A list of mental health resources was included in the email. Electronic informed consent was obtained from the participants before they could access the questionnaire. Participants' involvement in the study was voluntary. The inclusion criteria were all doctors working at Livingstone Hospital, Port Elizabeth Provincial Hospital, and Dora and Ginza Hospital. Doctors were excluded if they disagreed to participate or if they were not working during the COVID-19 pandemic. In terms of measurements, participants completed a self-administered electronic questionnaire which comprised 5 parts. Firstly, a socio-demographic and occupational questionnaire was designed by the authors, which include questions on mental health history as well as history of smoking, alcohol, illicit substances, and prescription medication use. The questionnaire also included the Oldenburg Burnout Inventory. The Oldenburg Burnout Inventory is a 16-item survey based on the job demands resources model. This inventory covers 2 dimensions, namely exhaustion and disengagement. This burnout inventory consists of multiple questions for each dimension and has responses in a 4-point Likert scale that ranges from strongly agree to strongly disagree. The Oldenburg Burnout Inventory includes both positively and negatively framed items that improve psychometric balancing of the inventory and reduces the likelihood of answering bias. It's important to note that professional efficacy or accomplishment is not included in the Oldenburg Burnout Inventory, as it is considered by most to be the weakest burnout dimension. Previously, the Maslach Burnout Inventory was regarded as the gold standard of burnout surveys, but this has been criticized for having exhaustion and cynicism items framed negatively and all professional efficacy items framed positively, which may lead to answering bias. In this study, work stress was measured using the generic job stress questionnaire that was developed by the National Institute for Occupational Safety and Health. The NIOSH permits that subscales of the generic job stress questionnaire be used independently to determine work stress. This study focused on 5 subscales, namely workload and responsibility, conflict at work, role ambiguity and role conflict, job satisfaction and support at work to evaluate occupational stress. Role ambiguity is defined as ill-defined tasks, and role conflict is defined as conflicting demands at work. In the generic job stress questionnaire, some items like job satisfaction and support at work are positively oriented. Accordingly, high scores for these items indicate lower stress levels. In contrast, conflict at work and job ambiguity are negatively orientated. And these scores, which are when high, represent higher stress levels. For our study, resilience was measured using the Connor-Davidson resilience scale. This scale has 10 items and uses a 5-point Likert scale that ranges from not true at all to true nearly all of the time. Greater resilience was implied by higher scores. Our questionnaire also included questions related to COVID-19. These questions related to previous infections in participants and the transmission of COVID-19 to their family members. It also addressed a few work-related issues regarding the provision of PPE and IPC, redeployment to other workstations, and the cancelling of annual leave. To address interventions to reduce stress at work, participants chose from a list of 13 interventions which would assist with reducing stress at work. All data collected was analyzed using Stata 15. Analysis included descriptive statistics of sample demographics, occupational and general health characteristics, burnout prevalence, and attitude to preventative interventions. The association of burnout with demographic variables, work-related variables, COVID-19 variables, and the 5 generic job stress subscales was analyzed using logistic regression analysis. Unadjusted and adjusted logistic regression analysis for age and gender was conducted to investigate the association of burnout with host factors and work-related factors of interest. In terms of results, the results of this study show that the total of 296 doctors participated out of 430 eligible candidates, representing a response rate of 68%. However, 36 questionnaires were not completed and therefore not used in the analysis. Therefore, 260 questionnaires were finally used and analyzed for this study. With respect to demographic and occupational characteristics, participants were predominantly female and young, with 43% in the 20 to 29 years age group. Medical interns formed the dominant occupational group, followed by medical officers and medical specialists or consultants. Participants had an average of 2 years of service and 96% were in full-time employment. In this study, participants felt the need to use different substances to assist with the management of work-related stress. 17% of the participants felt the need to smoke cigarettes, 21% felt the need to drink alcohol, 5% felt the need to use illicit drugs, and 7% of participants used non-prescription medication. Mental health disorders were highly prevalent, with 25% of participants reporting a diagnosis of a mental health condition. A further 18% of participants reported being on treatment for a mental health condition currently. Of the 25% of participants reporting a mental health disorder, 41% of participants had been diagnosed with depression, 18% with depression and anxiety, and 17% of participants had been diagnosed with generalized anxiety disorder. Interestingly, only 8% had prior diagnosis of burnout. Using the Oldenburg burnout inventory, the prevalence of burnout in the participants was 78%. An equal number of participants were exhausted and experienced non-burnout. Only 4% of the participants were disengaged. As regards the NIOSH generic job stress questionnaire risk factors, 50% of participants experienced medium levels of workload. Over a quarter experienced high levels of conflict at work, and a third experienced high levels of role ambiguity and role conflict. Almost a third experienced low job satisfaction, and almost a quarter experienced low levels of support at work. Based on the CD risk score, a quarter of participants had high levels of resilience, while about half had medium resilience, and the remaining quarter had low levels of resilience. Regression analysis indicated that for the study, burnout was significantly associated with being a medical intern or community service medical officer and being in the lowest income band. Our study did not show any significant association between burnout and socio-demographic factors such as age, gender, and relationship status. There was no significant association between burnout and occupational speciality. In the unadjusted univariate analysis, burnout was significantly associated with working overtime. However, this association was attenuated when adjusted for age and gender, and the association was no longer significant. With respect to general and mental health characteristics, burnout was significantly associated with feeling the need to use alcohol to manage work-related stress. It is unclear whether alcohol use preceded or followed burnout due to the cross-sectional nature of the study, but it may be possible that doctors were using alcohol as a maladaptive coping mechanism to ease work-related stress. Medium resilience and high resilience were found to be significantly protective against burnout in our study. As regards the occupational predictors for burnout, burnout was significantly associated with high conflict at work and high role ambiguity and role conflict. Participants with medium role ambiguity and role conflict were also more likely to have burnout. Those participants with low job satisfaction and low support at work, and medium job satisfaction and medium support at work were also at increased risk of burnout. Workload was not significantly associated with burnout. This could be due to the timing of the study, as doctors may have recovered from the high workloads experienced during earlier peaks of the pandemic. With respect to aspects of COVID-19, 56% of participants had been infected with COVID-19, with 49% having fully recovered from the infection and 6% of participants still experiencing symptoms. Almost 20% transmitted COVID-19 infection to their family members, and 39% had to care for an infected family member. Regarding workplace interventions, 49% of participants felt that they had been given adequate supply of PPE, and 45% felt that adequate implementation of IPC measures and policies had taken place. Almost a quarter of participants had been redeployed to another department during the pandemic, and over half had to change their annual leave. The majority of participants had received vaccination against COVID. However, in the study, while some factors related to COVID-19 infection and workplace interventions were associated with burnout, none of the associations were statistically significant in the unadjusted analysis. Possible explanations for this could be that the study was conducted in the fifth wave of the COVID-19 pandemic, by which time the acute workplace stress resulting from increased hospital admissions for COVID-19 had reduced. Secondly, it may also be that during the study period, more knowledge regarding the threat of COVID-19 was available, and the uncertainty resulting from the pandemic had lessened. And finally, vaccination was at that stage also widely available, thus substantially mitigating the risk of COVID-19 infection in the workplace. These findings suggest that high burnout levels in our study were less affected by COVID-19, but may be attributable to ongoing organizational challenges. Previous studies have identified poor working conditions and staff shortages to be contributory to burnout, while management support was found to be protective. In this study, interventions supported by doctors include employing more staff, improving working conditions, improving equipment supply, and management support. Surprisingly, in this study, provision of psychological counseling was less supported. This may be because doctors in the frontline units, such as the ICU, emergency department, and some of the medical units, had received fortnightly debriefing by the staff psychologist during the previous 4 waves of the pandemic. Interestingly, in our study, the least supported interventions were reducing workload and improving supervision. The study had some limitations. Recall bias was unavoidable as data collected were based on participant self-reports. Response fatigue may be another possible reason for lack of participation, as another burnout survey had been conducted a few months before the start of the survey. The healthy worker effect may have resulted in an underestimation of burnout, since doctors impaired by burnout may have resigned, leaving healthier doctors behind. As a result of financial limitations, the Maslach burnout inventory, largely regarded as the gold standard in the diagnosis of burnout, was not used in the study. Finally, the cross-sectional design of the study precludes the evaluation of temporality and causality of the observed associations, since there was simultaneous collection of both exposures and outcome data. Based on this study, several recommendations using a hierarchy of controls are proposed at an organizational level to mitigate burnout in doctors. Environmental controls recommended to mitigate occupational stress and burnout involve employing more staff, improving working conditions, increasing equipment supply, and intensifying management support. Recommended administrative controls include developing clear policies and guidelines to address organizational culture by promoting civility and mitigating conflict at work to ameliorate discordancy amongst doctors and between doctors and other healthcare workers. To reduce fatigue and exhaustion in doctors, a re-evaluation of human resource policies regarding overtime is recommended, and reasonable time limitations on the duration of shifts is proposed. This study highlights the need for the implementation of acceptable and sustainable mental health interventions as PPE to reduce the occupational stress and burnout in the workplace. It is recommended that specific therapeutic programs addressing coping skills, resilience, mindfulness, and self-care strategies should be offered to all doctors, especially junior doctors starting their careers. To assist doctors with mental health conditions or substance abuse issues, specific interventions should be aimed at identifying and assisting this group without stigmatization. It is recommended that doctors be involved at an organizational level in planning and designing policies and guidelines to improve the working conditions of doctors. Therefore, in conclusion, the study revealed that the prevalence of burnout amongst medical doctors in Gqeberha pandemic was high. Secondly, that factors associated with burnout include conflict at work, role ambiguity and role conflict, job satisfaction, support at work, and resilience. Given the strong associations with job stress factors and burnout, it is recommended that the management and mitigation of burnout should focus on interventional measures implemented at an organizational level. The following people have to be acknowledged for their assistance during this research study. Thank you.
Thank you, Saajida. Very interesting presentation. We'll take questions from the floor now. I can't see all the hands, so yeah. Please just put up your hand if you have a question. Okay, I'm going to kick off with a question. Oh, Leslie. Leslie, go ahead.
Thanks very much. It was really great. So I really enjoyed listening to that. I wonder if the attempt by health workers to do something about difficult conditions was measured or could have been measured. And I say that because I think this next week there's a seminar where the pediatric gastroenterologist who spoke up at Rahima Moosa Hospital is speaking about what happened to him. And in other words, whistleblowing, people's willingness to do something about the conditions and whether they feel a sense of control over the conditions might also be very important for managing workplace stress. So I just wonder if the survey looked at that, whether people had opportunity to try and change things around them and whether management supported them on that. Thanks.
Thank you, Leslie. Saajida, do you want to respond?
Institutions during COVID, there were certain issues identified by management, and through the collaboration of management and the departments, those issues were resolved, but not completely, and that's why a level of burnout still remains.
I think Leslie was asking whether in your study we also looked at sort of initiatives from staff to try and manage the stress, whether that was addressed. I don't think we actually did that in the questionnaire. Saajida?
No, we did not inquire whether specific staff members had implemented specific interventions.
Okay, thank you. Any other questions? Anybody else? Whilst we're waiting, so I was quite intrigued by your referring to strengthening of mental health and focusing on mental health and resilience as PPE. Maybe if you want to just sort of unpack that a little bit more, because it's not a conventional kind of thinking, you know, we think of masks and boots and gloves when we think PPE. But I mean, there was a recognition that mental health was very adversely affected during the pandemic, with many departments putting in place additional mental health support services, even, you know, bringing psychologists back onto the sort of institutional sites to provide support as needed. So I mean, maybe if you could just elaborate a bit on that.
Yes, Prof. I think traditionally we think of PPE as masks and gloves, but as the study has shown, there are other workplace hazards that we need to protect ourselves from, and these hazards may affect our mental health. Our study therefore proposes using different initiatives to protect mental health as PPE, and these include having a psychologist or even a EAP practitioner who will assist with initiatives to address coping skills, resilience training, mindfulness, and self-care of doctors.
Thank you, Saajida. Any other questions from the audience? Anybody else? I'm just going to ask one more question. Saajida, have you communicated your findings, as I know you've just gone through the whole, so by the way, Saajida has been awarded cum laude for a thesis. She's just gone through the whole process of having a thesis marked. Before I go on to my next question, Maylene, I'll give you a chance. Go ahead, please.
Thank you. Can you hear me, Saajida?
Yes, we can.
Thank you. Thank you very much, Saajida, for an interesting presentation. Do you have any sense of what and I might have missed it in the presentation, what the issues of burnout and mental health were pre-pandemic and post-pandemic in the same environment? Because the Eastern Cape Department of Health has also gone through some really difficult situations, and I know that at some point during the pandemic, Livingston Hospital didn't have a CEO, and the management of the hospital was really difficult. So I just wondered those sort of contextual factors, whether you have a sense of how different the burnout rates might have been pre-pandemic, and is there an opportunity to maybe look at this, but do the same study now post-pandemic and see if it's any different?
Thank you for that question. You seem to know the circumstances of the Eastern Cape health institutions very well. Yes, we have had quite a few challenges. In fact, at Livingston, we have not had a permanent CEO since 2018. And I think in the interim, we must have had about 20 acting CEOs. This has made the implementation of any policies incredibly difficult because there's been lack of consistency with the change of all the acting CEOs. In terms of the mental health conditions that presented prior to COVID-19, I must admit that we noticed in our occupational health unit that more of our younger doctors were presenting in 2019. Prior to that, very few of any of the doctors had presented. Occasionally we had received one, but they then had background history of mental health conditions prior to even qualifying. In 2019, we noticed the numbers of doctors presenting to us with mental health conditions. And I must say that since the COVID pandemic, doctors, I think, institutions per se have displayed more help-seeking behavior. So they've been more forthcoming and have to the occupational health unit requesting assistance. So I think there seems to have been some sort of sensitization regarding mental health that during the pandemic, which wasn't there prior to it. Prior to the pandemic, mental health was often viewed as a the doctors, and most doctors were almost embarrassed to disclose it. However, I must admit that since the pandemic, even during our medical surveillance, many of the doctors are very willing to disclose that they have been treated for or currently are being treated for mental health conditions. So I think positive, where it seems that COVID-19 has allowed this stigma to be broken, and this discrimination felt by seems to have been reduced as well. I would like to say that going forward, we would try to improve the conditions and working conditions of doctors, but I must say that a lot of it is dependent on our job, and right now we need a bit more permanence in that department.
Okay, thank you, Saajida. I think a complex situation.
I'm not sure if that answers your question.
I think it's quite difficult to answer. And I think Maylin is probably quite aware, as many of us are, of the challenges in the Eastern Cape. But Maylin, just to come back, I mean, from Saajida's literature review, and she can maybe also jump in, I don't recall us finding other studies done in the Eastern Cape. Other South African studies, though, have focused on occupational groupings. Like I think there's been one amongst registrars, and I think possibly one amongst anaesthetists. But it did show remarkably high levels of burnout. And I don't know whether it is just a feature of our society and our healthcare system. Because if one looked, I think she looked at systematic reviews also, and the range of burnout was really quite high. So it's sort of a very wide range. But I'm not aware of studies prior to this that was conducted in the same setting. Jana Groenewald, want to pose your question?
Yes, can you hear me?
Yes, we can. Go ahead.
Okay. Saajida, yes, thank you for that. I'm just curious as to whether these research results are also presented to undergraduates who are at the at the edge of graduation and knowing what they might be potentially, be in for. I kind of see it as, soldiers on the forefront of a war, and then, just equipping them with what they can expect potentially in the next, 2 years or 3 years, which is your internship. So is this also being, relayed to undergraduate students? That's my question, as a part of awareness and, to identify it early on if you are struggling, perhaps as an intern. Yes.
Yes, I think we will definitely look at relaying this information to our undergraduates, and definitely undergraduates at many of the universities, because we find that the interns that come to Livingstone and rotate through the 3 hospitals often come from Stellenbosch and Pretoria and Free State, where they may have been exposed to different working conditions, which may not be as challenging as what they will find at Livingstone.
Yes, all right. Thank you, Saajida.
I think that's a very important comment and potential area for intervention, Saajida, in terms of disseminating your results a bit further. Yeah. Are there any other questions? And I just wanted to comment the issue of, I mean, I think we could clearly see that the interns and the ComServe doctors posed a very, very high risk group. And I think normally when one thinks of burnout, you think of sort of cumulative stress over time, but certainly these are people just entering the profession and being at such high risk. So I think the intervention that's proposed is a very good one. Any other questions for Saajida? Maylene?
If there's no one else, Shahida, I think there's just one other number that struck me, is that quite a large number of the participants were married or are married, and I just wondered the extent to which, as the larger proportion of the participants are also women, the kind of support, if they had children and so forth, in the home environment, whether that added to some of the stressors. But just an observation from the health policy and systems side, that we very often concentrate on the hardware of a system, so the numbers of people, the equipment, availability of this and that, but clearly the study shows very, very strongly it's the software aspects that fundamentally can not just seriously harm and destroy people in the system, but also the system itself.
Thanks, Maylene, for the comment. Saajida, do you want to respond to Maylene's question around support systems, marital status, and childcare?
Sure. In our study, we did not
Sorry,
any
Saajida,
increase in
we're losing
burnout
you.
based on.
Can you just repeat yourself, please? We lost you there for a second.
Okay. In our study, show any association between burnout and marital status. However, the literature reviewed showed that being married was associated with a reduced rate of burnout. However, having children was associated with increased rate of burnout because it then increased the work-life dynamic and increased the work and stress at home.
Was it something we
So I
measured
don't know
in
if that
our
answers
study
your question.
and in your study, Saajida? You did ask about childcare, I remember. It didn't show
Yes,
any
we did ask,
association.
but yes,
Okay, does
the
it answer the
association
question,
between
Maylene?
burnout and caring.
Okay, Jana, is that an old hand? Your hand is still up?
No, old hand, sorry, old hand.
Any other questions for Saajida? Okay, doesn't look like there's any further questions. Saajida, thank you very much for a very interesting presentation. Thank you to all the people who attended and for your participation. Just to add that I think Saajida has been awarded cum laude for her thesis. So well done to her. A lot of hard work that went into it. And certainly, as Maylene has said, perhaps the basis for future work in the area. Thank you so much all.
Thanks, Prof.